This is The 1% Heart, a podcast that tells the stories of congenital heart patients, advocates, and providers, all shaping the future of CHD care. Today's episode is going to take it a step further into the part of heart disease that is not talked about enough, and that is what the heart does to the brain and how the conditions interact. These conditions shape development, school, focus, and mental health, and the people that study these conditions want more patience in the conversations that shape the care. There's an entire field working on that question, and today I have two people at the center of it. Dr. Tom Miller is a pediatric cardiologist and division chief at Maine Health. He's a fetal cardiologist by training, meeting the families before their child is even born and staying a small part of their lives for years to come. He helped build a cardiac neurodevelopmental program from the ground up. Cardiac neurodevelopmental is one of those phrases I really struggle with, and you're going to hear it a lot today. Andrea Smith is a pediatric nurse who spent 12 years in the pediatric ICU before making the ultimate pivot. And that is what we're going to talk about today as well. She's now coordinating the heart-centered neurodevelopmental program at the University of Utah and co-chairs CNOC's programs and meetings, CNOC being the Cardiac Neurodevelopmental Outcomes Collaborative. Together, they're planning the CNOC 2026 scientific sessions where the field is meeting and discussing later this year. And we're going to talk about why they want patients there. That is my 2-minute introduction with a lot of big words. Since neither of you have been on this show before, do you want to give me a quick version of who you are and what you actually do? Andrea, you can go first.
Sure. Yeah, I'm Andrea Smith. I'm a pediatric nurse by training. I have since then moved into a very, as you said, subspecialized program development for cardiac neurodevelopment. So I coordinate the program here in Utah. We do work on the inpatient side with patients and families that are in the hospital following their cardiac surgery. And then we work in the cardiac neurodevelopmental follow-up program, outpatient clinic, and do formalized testing in different developmental areas throughout childhood.
So many big phrases, and I can see why you guys like acronyms so much. Tom, do you mind giving us a bit of your background?
Yeah, so as you mentioned, I'm a pediatric cardiologist, which means I train in pediatrics first, and then you do subspecialty training in pediatric cardiology, and then many of us do a subspecialty within pediatric cardiology. So my focus was on imaging and fetal cardiology, so making the diagnosis of congenital heart disease before babies are born and meeting with families and getting to know them and talking about everything that we expect to happen after the baby's born. And then my other hat, obviously, why I'm here is related to cardiac neurodevelopment, which has been a focus of a lot of my work and career as well. In terms of your question of what I do, every day is different, which is why I like pediatric cardiology. So sometimes I'm in the hospital, sometimes I'm in the OR and the ICU, working with patients going through surgery. A lot of times I'm in clinic. And then more recently, I've had a fair amount of administrative roles as division chief to sort of figure out how to best deliver care, which is an ongoing work everywhere across the country to figure out how to best deliver, and not the least of which is how to deliver cardiac neurodevelopmental care.
Got it. So it's a focus inside of a subspecialty, inside of an advanced specialty, inside of okay. I think I see it in my head, but I'm gonna have to listen to that part a few times as well. So you're a heart doctor who ended up focused on brains. Can you tell me how that happened?
Yeah, like a lot of things, it wasn't exactly my original plan. You know, we always ask trainees what they want to go into. It's, as you mentioned, it's such a subspecialty field. I think when you talk to med students and residents, they don't even know about cardiac neurodevelopment. When I was junior faculty at the University of Utah, my first job out of fellowship, the field was sort of growing and developing, and a lot of centers were starting to develop cardiac neurodevelopmental follow-up programs. And we had a very good division chief who was in touch with everything that was going on around the country, and he wanted to invest in one at the University of Utah, and he asked me to help direct it. And so really that's how I got started in the field, was developing the program at the University of Utah based on the direction of the division chief at the time, and a lot of investment from the university and the team there.
Understood. And one of the notes we had sent back and forth, you had mentioned a very impactful story about a huddle. Do you feel comfortable sharing that?
I think you had a prompt where it was, how do you know this is important, or I forget what the exact prompt was. I apologize.
Yeah, I like to jump the gun.
Yeah. One of the things where I realized how important the field was, because I said I was junior faculty. To be honest, some of it was doing what I was told. I knew all of it's important, right? Any aspect of the field is important, and you just feel honored to be asked to lead an aspect of a division in a heart center. But when I really realized how impactful and how important it was and how much we needed to continue to invest in it was, there was a huddle. So the way we started our program, many programs are similar, is it's very multidisciplinary, meaning lots of different disciplines, lots of people who have trained differently. So psychologists, speech therapists, audiologists, geneticists, developmental pediatrician, cardiologists, they're all the way we did it at first in Utah was a group of kids would come in and they'd meet with all those people. And at the end, we'd make sure that we had a solid idea of what the plan was moving forward. Because we didn't want to just give an assessment and then go off into the ether. So we had huddles at the end to make sure to gather everyone's thoughts and figure out next steps. And there was one where it seemed like just a normal interaction to me. Nothing jumped out at me for my part of the visit with this one teenager. And everyone else came in and, immediately everyone else in the room, all those other subspecialists said, "Oh my goodness, I can't believe I feel so bad how depressed that child is." And it dawned on me how much when you're just focused on the heart, you can miss what's obvious to everybody else and what's probably the most important thing in that person's life at that moment. I mean, obviously we need to follow the heart. We need to make sure we're on top of the aspect that the cardiologist is responsible for, but it realized how often in a quick clinic visit, a cardiologist or even a pediatrician or others can miss what is so obvious to other people that are looking through a different lens because it was so obvious to everybody else.
Yeah, I mean, it shows that's a success story in a way. I mean, you guys have all these different specialists meet, and then you bring them together and have them talk to each other, and it opens a lot of eyes. So it's a painful story, but in a lot of ways, it's a success story proving how valuable it is what both of you do. In my opinion, I'm the optimist if you can't tell. Andrea, I want to apologize. I think I've mispronounced your name 2 different ways now.
You're fine. Andrea.
Which is great because I've only met you a dozen times. So, Andrea, what does a neurodevelopmental program coordinator actually do? Because it sounds like one of those jobs where you probably do a lot of everything.
Yeah, no, that's a great question. And when I was leaving the ICU and moving back to Utah, I honestly, when I applied for this job, had no idea what it meant. So I think it's a very fair question. And it is a lot of different hats. So I think day to day, it is I don't know, I guess like the quarterback of like connecting the dots, running the plays. So I want to make sure that everything is connected between the patient and family and the physicians, whether that's a cardiologist, a developmental pediatrician, the surgeon, and then all of the subspecialties that Tom was talking about. So our physical therapists, occupational therapists, speech therapists, as well as the school and any mental health providers. So that's a lot of players. And I want to make sure that everybody's on the same page and then help navigate that patient and family through that journey. Because as we know, a child isn't just one system, right? They're not just their congenital heart disease. They are a whole person. And so when all of those players are on the same page and playing together, it makes it that much easier for that child to be successful. And then on the kind of back end, I do a lot of program development. So really focusing on how to make the system better, both in the hospital and in our outpatient follow-up program. So that's a lot of like scheduling things, system things, referrals, making sure that any of those communication tools are actually going where they're supposed to. And then big picture is research. So some of that is just done locally. So I do research locally on like parental mental health is really where my passion is. And then on the larger scale is with CNOC, the Cardiac Neurodevelopmental Outcome Collaborative. And that's really how do we move this forward? So cardiac neurodevelopment is really pretty young as a field. The first scientific statement came out in 2012, which is not that long ago if you think about that. And so we've got a ton of work to do. We've made a ton of progress in the last, 14 years, but there's so much more to learn. And so a big part of my role is figuring out how are we making sure that the outcomes and the things that we're doing in our clinic are getting to the people that are doing the research and really pushing this forward. So I feel really lucky. It's funny, Tom and I now work really closely together with CNOC, but we never actually overlapped in Utah. So I was in Oregon as an ICU nurse, and then I moved back, I think a year after Tom left, something about that. So the program that he started in Utah, those kind of fundamentals were the huddles that we do. We still do that at the end of clinic, and it is a hugely valuable part of our clinic because it really does get everybody on the same page. Everybody is seeing different things. And so we bring everybody together and make sure that we are looking at that big picture and hearing from all the different specialists. And then we give that feedback back to family. So that's another one of the things that I do as the program coordinator is after that huddle, if there's things that came up that maybe weren't talked about in the appointment, I then follow up with families. I call families and talk through it, make sure that they're understanding kind of what we did in clinic, any of the diagnosis or referrals or suggestions that we're making, and make sure that they're on the same page of how to best support their child. Because at the end of the day, they're the ones that are going to lead that, and they're the most important part of it.
I like how you ended with how the structure and system Tom set up is still in place and working while you're there, because the 3 full job descriptions you gave that you do, and I kept getting more and more anxious, are all about, I mean, one of it, the day-to-day is managing different stakeholders for the patients. And then that process, which I thought was the entire job. And then you added 2 more. I felt my jaw clench and unclench a few times there. That overwhelmed me. And the next part of it was making the processes and systems better so that can be done more effectively. And then the third part was pushing the field forward in much the similar way. It's a lot of stakeholder coordination is the MBA bullshit term. It's a lot of keeping people on the same page.
That's great.
And getting them there sounds hard. Sounds like if as someone who hasn't had to do either, I think I'd prefer being the doctor to the coordinator, treating something than getting
It's so much easier. Yeah, I could tell you.
Well, but,
I mean, what Andrea does,
you're managing doctors now.
What Andrea does is so much harder than what I do. And I'm so glad to hear you say, Andrea, how much you see your role as connecting the clinic to the research arm, because I think one of the reasons I was asked to do this was because, so another piece of my background is actually a fair amount of research in my background, and some of my additional training was in doing research and at a lab, and did things with rats and et cetera, et cetera. But I think one of the reasons the division chief asked me to do it was because he wanted to build it in a way that it moved everything at the same time. So it wasn't just living in a silo of developing neurodevelopmental follow-up with psychologists. It was getting the cardiologists involved, understanding what we were doing, being, you talked about buzz terms, and business, the buzz term now in administration is a learning health system, right? So you learn as you go from what you're doing with all the stakeholders that are involved. And one of the things that I think they still do in Utah, we always did, I know they're doing it in Utah, that is really what we do nationally, and what's driven by CNOC, the Cardiac Neurodevelopmental Outcome Collaborative, is making sure patients and families are at the table, because they're part of the value of figuring out what we need to learn from to continue to do better and make sure what we're providing is of highest value when we invest in this type of care.
And that is a perfect tie-in. So I'm going to skip any more of the questions I sent over beforehand were just suggestions, and I'm not going to follow them anymore. You guys have both mentioned CNOC, and this is a great time to talk about it because this is a rapidly advancing field. We have spent decades working on how to help congenital heart patients survive. And now we're finally to the point where we can help brain development and help them thrive and coordinate all that care. So, and because it's advancing so rapidly, I think CNOC, so the research you're talking about and CNOC itself is such an important part of that. But because I can't say neurodevelopmental outcome without talking over myself, who wants to take the description of CNOC and why it is so important to have patients at the table, like you said, Dr. Miller?
I guess, I can start. I think it's always been part of the mission. I mean, so a plug for the website for people that aren't as familiar with CNOC, www.cardiacneuro.org.
And I'll link that in the show notes as well.
Okay, if you just Google CNOC, and there's a patient and family tab and drop down, which is, we're hoping to expand even more in terms of references and relevant information. But in the bylaws of CNOC are having patient and family advocates on every subcommittee, just because that's the way it's been envisioned from the beginning. Trying to remember what your exact question was. Why do we, it's just critical. It's mission critical, I guess, is the way to, is a quick answer to that. Because the thing about cardiac neurodevelopment, so as a cardiologist,
what is CNOC?
So CNOC, great question. So CNOC is a multi-center, multinational collaborative of institutions and individuals who are working together to improve the psychosocial health and well-being of individuals with congenital heart disease.
CNOC is the Cardiac Neurodevelopmental Outcome Collaborative, and it focuses on the cardiac neurodevelopmental, so the heart-brain connection. And it's a bunch of really passionate and intelligent researchers from all medical walks. And I use that term broadly because it's everything from neonatologists to biochemists, or what it is everyone who has a passion for CHD patients. This is some of the hardest work I've seen out there, and it's some of the least glamorous in terms of recognition and reward for it. But the reward is helping the 1 in 100 kids born with congenital heart defects thrive, not just survive, but thrive. So that is my layman's definition, but a very passionate layman. Sorry to cut you off there, but that is, for anyone listening, The whole point of this is the scientific sessions, which is their annual conference, are coming up. You can attend in person or virtually. All the detail will be talked about more, but also in the show notes. And it is the chance for the people who care deeply about patients and their families and where they're at now to hear from patients and their families. That is what today's episode is about, is getting anyone listening to this at the table to watch enough to shoot their notes over. Because if you're listening to something and you have a thought or an experience, it helps. So
For sure.
that is my hard plug, but please continue with the actual reasons that it's so important to have patients there and not just my sales pitch.
Yeah, no, I think to boil down your question of what is CNOC, I mean, the simplest answer is it's a community. It's a community like you describe.
I'm stealing that.
But that's the way we really feel. I mean, as you say, in some aspects, it's hard because it's much more complex than some of the other subspecialty. I mean, there's so many great subspecialty organizations that have annual meetings, right? That, for example, as an imager, someone who does echo, right? There's American Society of Echo. And that's a great place to be with the cardiologists who just love echo and mostly focus on echo. The thing that is different about CNOC is it's so broad in terms of the subspecialties of people that come together, that really what binds everyone together is not that you're an imager, or that you're a surgeon, or that you're a psychologist or physical therapist. It's your focus on the bigger picture of what is sometimes really hard to define, of the outcome of just a good quality of life for kids and adults with congenital heart disease. And so what that means is how that translates for me sometimes is, as someone who wants to write a grant or a paper, it gets really messy because it's much harder to sometimes have a strict outcome and say, I'm definitely going to do this exact thing. But the community is what makes it so great, because you're also there are things where you meet and you hear what someone else is doing in another center, and you just say, I don't need to study that. I just need to do it, because that makes a lot of sense. And I don't need a randomized clinical trial to know that it's important to treat mom's anxiety in fetal clinic, right? So, and this is how this group over here is doing it. So a lot of the value, we've actually struggled with, how do you tell hospital systems to pay for the time to go to meetings like this? A lot of the value is just being part of the community. After the pandemic, I can tell you the first meeting that almost everyone who goes to CNOC wanted to go to was CNOC. It wasn't, I won't even say which ones it wasn't, because I don't want to throw any other associations under the bus and any other meetings, but it was just, I think the phrase I often hear is like, oh, these are my people. Like, these are the people that I have the most interesting conversations with, that most impact and translate what I'm going to do differently when I go back to my center. Because for us, for physicians at least, a lot of going to national meetings is like to be reinvigorated and come back with some ideas back to your center about what you might change your practice, how you might do things differently. And that's why sometimes these Zoom meetings, or when they went to hybrid in COVID, or if you just log in and listen to lectures, it's not the same as being at a meeting. And the CNOC scientific sessions is that to the nth degree. And one of the things that motivates us so much is hearing from patients and families. And I can tell you, so many people within CNOC have changed their practice, have changed their research, have changed their administrative approach to delivering care because of things that they've heard from families and patients at CNOC meetings.
Yeah, I would definitely add to that. I totally agree that if you had to pick one word to define what CNOC is, it is a community. And really that is felt throughout our collaborative. I think one thing that's unique to our scientific sessions is we really are very purposeful about building in time for collaboration. So, I mean, there is hardcore cutting edge science being presented. Absolutely. There's some lectures where, like, by the end, I'm like, whoa, that was a lot of information. I'm very overwhelmed. But we always build in every session, in every day, time for collaboration. So each of the sessions ends with a question and answer that's very interactive. And one of the things I love is that there's always patients and families that stand up and ask the questions. So I think it's a very welcoming community. And then we build in things like, we've got 3 breakout sessions this year that focus on kind of different areas, but each one of them would be applicable for patients and families. So there's one that's really focused heavily on research, but some of that is how patients and families get involved in research. And so we try to really tie that in. And then there's some QI work that's happening, mainly inpatient kind of work, and quality improvements. So I think of the main difference for me in QI and research is that quality improvement happens a lot faster and you can see results, where research tends to take a bit. So we've got a whole group focusing on quality improvement on the inpatient side, and that doesn't happen without patients and families. And then the kind of third one is really focused on our outpatient programs. And again, some of the feedback that we're getting is from patients and families. So the collaboration that happens at these meetings, that's what everybody talks about. Yes, they learn things, and there's people that are really pushing this field and doing really, really cool things with imaging and brain monitoring in the OR. It just is, there's people that are doing really great and cool research. And then you pull everybody together to have these conversations. And like Tom says, it advances the field a lot, because you don't have to necessarily, I'm not going to go home and say, I need to recreate this research. I'm going to reach out to the people that were at the meeting and say, how did you do this? How did you change your program? How can I do it here now? And so I think that was really, from the beginning with CNOC, that's been the goal, is that we know that we've got a lot to learn about cardiac neurodevelopment. And so we're going to be stronger and faster as a group than we would be as instead of an individual program or an individual institution trying to advance this field alone. And so I really think that that's what this boils down to, is a community that is very collaborative, really wants to partner with each other. There's not competition. It's how do we partner together to advance this field and make it better for patients and families?
To go out even one more layer, that's actually the whole vision of Cardiac Networks United. So CNOC is one of the many collaboratives that are part of a bigger universe, what's called Cardiac Networks United. And one of the first ones was PC4, the Pediatric Cardiac Critical Care Consortium, which again, like Andrea said, the goal was never to be competitive. It was to benchmark ICU outcomes. And the way that their dashboards work is you can pick an outcome that you look at, and if your center is a low performer, you just call the center that's a high performer and say, what are you doing differently? So the whole community, we're one sliver. We think of ourselves as one sliver of the bigger Cardiac Networks United, but it is a shift from the concept of competition and ranking and, who's the best, to like, how do we just make everyone the best that they can be across the country in advanced care for everybody?
I'm glad for that. The last part, you guys kept building on each other, but I never really thought about how that would impact it. Competition versus collaboration. I mean, anyone who knows anything about medicine knows it's a very competitive field to get into and to stay in, and it permeates throughout. But this is such a rapidly advancing field where everyone can help each other. But you guys built on each other and you did it great. And you guys both glossed over the biggest part, the best sales pitch for CNOC, in my opinion, because it's one of the reasons that I started this podcast after CNOC 2024 was because y'all are so smart, but I've never had to sell anything. So let me tell you what the sale is here. It is interdisciplinary. It is people, these specialists from all walks, including patients and their family members and advocates. And you guys bring in even the heart charities that do so much, like the Adult Heart Association, which are advocacy groups. Getting that breadth is critical because, it's your Andrea's whole job is trying to coordinate 20 different specialists for one kid and the school programs and getting the patients the mental health care that they need. So getting the research and practitioners of all those different walks of life in one room for 3-4 days, it's a hell of a thing you guys are doing.
Thanks. We just enjoy it getting together. I could say the other thing, it's sort of grounding to the interdisciplinary aspect of it. To your comment about competition versus collaboration, I feel like when you get in a subspecialty, that's where, and you get so narrow, that sometimes is what breeds competition is, I'm going to be the best in this because, and it's just naturally a lot of the way we're trained and the way marketing works, and, get on a whole soapbox about how that works with hospital systems. But when it doesn't matter if you're the best in your niche, if you have to consider all these other 20 million different aspects of the care of the child, like you just need to talk about your aspect of it and figure out how it best intertwines with the other people that are experts. Because there's no way you're the best at everything of all the disciplines of people that are there, right? Even if you're the best in the world of your subspecialty, as you mentioned, there's 40 other subspecialty disciplines. So you have to collaborate to advance your own work and your own science. And hearing from families and patients at the meeting is a piece of that. Because I can tell you, you're definitely not the expert in someone else's kid. And so you need to hear from parents about that aspect.
And let's be honest, there's not enough people in each of these subspecialties. for years, it's been helping CHD patients survive, which as a CHD patient who survived, I'm very grateful for that research and I'm not discounting it. But this is a whole nother step. This is patients are surviving. How do we help them thrive?
Yeah. And it really was about survival. And then now surgical advancements and just even early detection has made such a huge difference that kids are living, into adulthood and living long. Our goal is happy lives, right? And so I think that that's part of, this field being relatively new, is that we actually didn't know a lot about some of these, mental health, executive functioning challenges that people with congenital heart disease can face because there weren't enough of them living that long, right? And so now it has to be driven by those experiences because otherwise we wouldn't know what to even be looking for. So I think there's been so many moments at the past CNOC meetings where people have kind of stood up and it's like the whole audience has this aha moment because there's a patient or a family that's like, I actually had that experience, and will lay it out in a lived experience in a way that is just relatable as a human. It doesn't matter if you have a structurally normal heart or not, it's relatable as a human. And so there's just this aha moment that happens of like, wow, yeah, that's why we're all here. And so Tom started our program in Utah, and we've gone through lots of different ways to try to capture as many patients as possible to bring them into our program. That's changed over the years. And I will see patients in clinic that are like 13. And it's the first time that they've come to our clinic, where normally we see kids at like 9 months old and we try to follow them throughout their childhood. And the conversations I have with families about their 13-year-olds we're talking about neurodevelopment, the parents are like, why didn't I hear about this? Why is this the first time that we're in this program? It's like, well, it didn't really exist when he was born or when she was.
Can confirm.
Yeah. And so it is a little bit of that heartache because they're telling me about these struggles that they had no idea could at all be related to their congenital heart disease. They thought, well, one example is like our patients that are born with transposition of the great arteries. So like their main big vessels in their heart are switched. And if you have a good surgery in general, as a newborn, it's like a one and done kind of surgery. It's just fixed. But those kids are actually, what we found research wise, is those kids are one of our highest risk populations for neurodevelopmental challenges. And so talking to families, they're like, well, I thought they fixed the heart. So why would that matter? How is that related to the ADHD or the anxiety that we're seeing now as a teenager? And so I think it's important to hear those stories so that you can connect it, because otherwise, why are we doing this, right?
Yeah. And there are so many great parts of that tie to, I've kind of thrown out the script at this point, but tied to the things I wanted to get across. So it's great what we're doing for patients now. And the whole reason that I'm so passionate about all of this is because of how shitty, for lack of a better term, my experience was growing up. I think I had at least 10 different cardiologists growing up. Some of those were just adult, non-congenital heart disease cardiologists. I did not know that I had what was called a CHD until I was in my 20s and lucked into the Vanderbilt CHD clinic. It was December of 2020 and I got COVID, and they sent me to a cardiologist for a checkup, and he said, why are you here? We have an adult congenital heart disease wing. I have 3 heart surgeries, one of them open growing up, and I did not know that this was a thing until he sent me to it. So I guess COVID was a good thing for me, and I hate to say that. You mentioned the impact of patient stories and tying it all together. And I take it a step further because I've based a whole podcast around this, where 1 in 100 people have a congenital heart defect. It's so common and we all seem normal. A great deal of us seem normal. And the power of those stories is, like, I have a friend who climbs mountains and teaches in Colorado, having a mechanical valve from his CHD. I have another in Scotland who has made his podcast while also going through follow-up surgery after follow-up surgery after follow-up surgery, who actually got me into all this. And it's overcoming those struggles in a way that is just so, explaining to the doctors and researchers at this conference what these people are doing now and what they had gone through to get there. I mean, you guys are having me give a whole presentation on it, the Friday sessions. It makes it resonate, but also is proof point how the things you're doing now for patients are preventing difficulties down the road. Like I'm on a monster dose of Adderall, which you can tell is not working that well right now because I'm all over the place. I did not know ADHD was related until I think I learned it at a session. I did not know what CPTSD was. I thought I had to sleep with a blindfold, a white noise machine, blackout curtains, and still didn't sleep because I was just an eccentric guy. A lot of these little things tie together in a way that is never discussed or found out unless you're getting these workups that you guys are talking about, and you're connecting all these different services, and you're following up with the patients and their parents. And I'm not even going to talk about my dad's obvious PTSD from my surgery, where anytime I bring up congenital heart defects, he goes, yeah, well, you're fucking fine. And I'll blurt out that swear word, but there's an impact like a pebble in a pond, and it branches out. And that's what you guys are trying to mitigate. And it's amazing that you're doing it. And if we can bring patients and their parents into the room to help guide that, it lets you guys attack it all that much better. That's my sales pitch. Anyway.
And I just want to say, like, that is our whole goal, right? Like,
Yeah.
that is the goal, is that your experience of not knowing that even you had congenital heart disease, and then all of the kind of other challenges that can come with that, like, that none of those things are related. Like, our goal is to make it so that that doesn't happen anymore for patients and family members, right? Because the more that you know going into it, even if it's not a challenge you yourself face, but if you're more aware of things to look out for, and maybe even putting in earlier intervention kind of things to mitigate those risk factors, then hopefully our outcomes are even better. And, every year we talk about, like, it kind of expands on the lifespan, I would say. This year, there's going to be a really great presentation talking about getting adult congenital patients involved in research and why that matters, like why community-led research is important. That's on Thursday. But really, like, every year we just kind of get bigger and bigger, where, we've got presentations about, like, aging in CHD, which is amazing. We used to talk about, let's get them till they're 3. So it is really, our goal is just to make it that much better for the next patient and family that's experiencing this.
And you just answered the
thanks.
question. Sorry.
Oh, go ahead.
You just answered the question I was building up to without realizing it, which was, we've made the case for why parents should be in the room and why young patients should be in the room, but why should adult patients be in the room? Not only is it to guide research and to make it so that others don't have their same experience and to let their experiences shape the care, but it's because they also get the benefit of having, if you're looking at me as an adult patient trying to figure out where my care went wrong, you're also diagnosing and assisting and giving me tools to do better going forward. So it's two sides of the same coin. I get the benefit of, hey, now I know what the hell is going on with myself, and you guys get to help this not happen to other people, which is, again, the sales pitch. That's why we need the adult patients in the room. Even if they're just on Zoom and they send follow-up emails afterwards, or they type their questions into the chat, the impact of it is everybody gets something out of it. It's one of those few times that anyone in business can tell you never happened. It's what's called a win-win. Those actually do exist.
I was going to say two things jumped out from your story there. One is, first, thank you as always, as I said, everyone, for sharing story and experiences that are very personal about, your medical history and what went on. The reason it's so valuable to hear those stories for us as cardiologists and other clinicians is we don't know what we don't know in terms of the experience. We have our own experience of the same trajectory of having taken care of someone through their childhood, and we think we know what that family heard because of what we said. And a way to simplify it is, sorry, let me back up. So to hear what you experience of bouncing between 10 cardiologists and not being aware that there was an associated risk of traumatic stress changes in your sleep patterns or ADHD, it informs us of how to better deliver care within the whole system. The parallel that I always think of is, as a fetal cardiologist, I deliver a lot of counseling and a lot of bad news at times. And of course, especially right after you graduate, you think you do a great job. I told them everything, right? And then you learn later in your career, don't quote me on this exact statistic, but there's some great statistic about processing things when you're stressed. And basically, once you hit someone with bad news, they don't hear anything else. So one of the biggest learning aspects of my career was another nurse coordinator, similar to Andrea's role. We had a fetal nurse coordinator, and she would do follow-up calls with the families after we did counseling. And to have her be able to tell back to me what that family heard, relatively short time after I had had a session of delivering whatever news I was delivering, it allowed me to learn about the care I was delivering and what actually the family experienced, and how the two weren't necessarily the same because of how they were processing everything. And it's not bad care, it's not missed care, it's not anybody's fault. It's just, you need to understand how it all connects. The running joke in fetal cardiology is when patients get to the CICU as babies and the families, and then the intensivists say, how come no one told this family about this diagnosis? Because if you don't understand that the a parent's brain may shut down the second you give them bad news. They're not going to recall everything. So then by the time they get to the CICU, the intensivist thinks the fetal cardiologist didn't tell them anything about the diagnosis. It's a long-winded way of getting around to, as physicians, we think we've done something, and we've done something, but it's maybe experienced differently than we thought it was experienced, and therefore the result of it is very different than what we thought the result was going to be. And so we need to learn from those experiences to change how we deliver care. And the second piece of your story that jumps out, that the collaborators or friends that you were talking about who are just crushing it right now in life, there's a lot of interest. We talk about being higher risk for things, but just because you're higher risk doesn't mean that you're going to have problems with this. And the things people have problems with happen to people without congenital heart disease too. So it's just being aware of it, understanding it. And one of the things that a lot of people are interested in studying is what creates more resilience in people who have the same diagnosis, went through the same ICU, went through the same multiple surgeries. And, we have one 10-year-old who can't get out of the car to go in the hospital because they're so stressed just seeing the hospital doors. And we have another kid who just walks in and holds their arm out because they know they're coming for a blood draw and then they're going to leave. Like, how does the neurocognitive adaptation to that, how is that different from individual to individual, and how can we better support that?
So there are like 4 things there I need to address. First, I'm incredibly thankful that you mentioned the fact that parents don't hear, like when I ask my parents about different parts of my care growing up, I was 6 months old when I had my open heart for the VSD and for the pulmonary valve repair. But then I was 2 years old and I had turned blue. Like I had turned blue. They had rushed me to one hospital, air vacuumed me to another, did the surgery. And when I asked my parents about that day, about what they said to them afterwards, the things they remember are not what the doctor, like my dad remembers how they can only send one parent in the helicopter. So he hopped in his car and he beat the helicopter there. Now, he wasn't carrying a baby with a bunch of tubes in him, so it doesn't really count as a win, but he remembers that. And my mom remembers other smaller aspects of it that are not, I'm sure someone told them what was going on, but they really learned about it years after. And I'm sure someone told me at some point what was going on, but I remember asking a cardiologist when I was 16, like, what does any of this mean? And he sat down and explained it to me for over an hour. And I took notes. It's incredibly difficult in the moment for a patient, let alone a parent, to fathom what's going on when they woke up that morning and their kid was fine. So I get that so deeply, and it's what makes this whole care network and follow-up so important. Something else you said there was building resilience. Every time I always end my episodes with, after everything you've done now, with everything that's happened, what does CHD mean to you now? And everyone, from the patients to the providers to the advocates, resilience always seems to come up. Now, the caveat to that is survivorship bias. To be frank, it's I'm not talking to the patients that aren't actively seeking out stories, or the patients that are avoiding even thinking about it. I'm not talking to the patients that have had that surgery and have fallen out of care. That's why I try to get this podcast so broad and focused on the stories on these other episodes. It's to get it in front of people who have probably not even realized they had a CHD, had a heart surgery, and don't realize it requires long-term care. I think it's like 75% of people that have simple or non-complex CHDs, whatever you medical guys call it, the ones where it's like a one and done surgery or a simple repair, they fall out of care. Like I knew a guy that had open heart that I met in my MBA program that fell out of care because he didn't know he needed to follow up. So I'm sure someone told them, but it's really tough to remember that when your world's on fire. But resilience it's amazing how many times I hear that word. And then I'm sitting down with you guys who don't want us to be resilient because you want to make it so we don't have to be resilient in a really weird roundabout way. There's a better way to say that, but I'm pushing us up on time here. And there's just a few more things I want to get to. So we've talked about CNOC. What I want to ask first is why is the heart so critically related to the brain in simple terms that I can understand? Because I'm neither a cardiologist nor a neurologist, and I don't think I've taken a chemistry course since high school. Anything I missed talking about with CNOC and how important to the patients it is, and I'm going to end with a really impactful question. So, why does the heart-brain connection matter? Explain like I know nothing, because right now, after you guys tell me about your backgrounds, I do feel like I know absolutely nothing.
You want me to go? So, the heart-brain connection, it's very complex. I think, and I don't profess to begin to understand all the complexity related to it. And we've tried I'm involved in research where we've tried to understand how the heart, brain are both impacted by placental development. And maybe that's a big driver, genetic variants and how much that interacts. I think the simplest way I think about it is when you think of a child's development or any adult's development, everybody's different and has variation in how they function, how much they're social versus antisocial, how much they can process things quickly versus shut down in stressful situations, how much they engage. And I think what we understand is that everyone's at risk to have things that they're better at and worse at. And when you add medical complexity to the equation, it just puts you at higher risk to struggle with certain things that everybody else might struggle with. And so things that the corollary is thinking about like a respiratory infection in my mind, right? Because this is just a little bit simpler to think about, right? What I tell a lot of families that have single ventricular heart disease during this one stage is that your child is probably going to have less reserve than some other kids this winter. So a respiratory infection that may give your other kid without heart disease just a runny nose and they have to stay home from school for 2 days, your child with heart disease may end up in the hospital needing some oxygen or some ICU level care. They'll be fine. They'll get through it.
I can also confirm that one as well.
Yeah, they'll probably be okay and they'll get through it, but just they have a little bit less reserve. So it's a long-winded way of getting to the way I think of how the heart impacts the brain is it gives you a little less reserve in terms of all the other million things that can affect your neurodevelopment and your psychosocial well-being. And it's not necessarily the most important, right? And we're actually learning that as we study as kids get older, the environment, the school, the social systems that we have in place to support people and their general mental health is a bigger driver, but you have an additional risk factor with congenital heart disease that you need to be aware of. And so rather than waiting or saying, my kid's already been through so much, so we're just going to ride this out. It seems like maybe they'll outgrow it. Know that I think Dr. Alardi was one on your podcast where she said, address that early. It's better to intervene on it early and be aware that you need to get the supports that we know help everybody, but are going to be important at that time. I don't know if that answers your question directly. The bottom line is the heart brain is complex, but they're related, and I think it's another risk factor.
And I would add that, kind of to your comment about your dad's kind of response when anytime you bring up your congenital heart disease is like kind of this like trauma response, really. I think one of the things, one of the big focuses right now in CNOC and in research is parental mental health and like that family unit, right? Because yes, the child's reserve is maybe less to Tom's point. And so then if you also have parents that are functioning with less reserve because of, what Tom does I don't think fetal cardiologists get enough credit or support. That is a horrible job in my opinion. I mean that with a lot of respect. But these families are coming in and they have this pregnancy that they're so excited about, and then they are devastated that is not a quote normal pregnancy. And then part of the fetal cardiologist's job is to set them up for success of like, this is what's going to happen. They're going to have an open heart. They're going to go to the ICU. They're going to have an open heart surgery. Oh, by the way, they're also at risk for neurodevelopmental challenges throughout their lifetime. There's obviously an art form to how this is all delivered. But so then you've got a child with less reserve whose brain may be developed differently in fetal life because of the pathway of the blood and the nutrients from the heart to the brain. So they've got less reserve. And then you send them home with these parents that are terrified. They've just seen their child go through unimaginable things. And then you kind of, without support, without a safety net, without a community, you just are like wanting them to succeed in this trauma-filled life. And I think that that's what we're really learning is that breaking down kind of some of those mental health barriers on both the parent and the patient early is really, really key.
No, very well said. I mean, everything you guys just said is resonating a little bit too much because looking back now, it's clearer why my family reacted the way it did. But in the moment, looking back, it seems like we kind of made CHD the enemy, made the insurance companies the enemy. We had, my dad had 3 other kids. I was my mom's first, but she was helping with the 3 other kids. They knew what normal babies were like. They knew what normal was. And it was probably the worst days of their life when it all went down. So the supporting the family, supporting the kid, and yeah, very well said.
But I think
Amazing
one of the
work
things that's so important of CNOC meeting and community, and we are so grateful and lucky that there are such great parent and family organizations, and there are too many to name that support CNOC, and we're so grateful. But I think part of it, I always see, is I always think the resilience often comes, sometimes if you realize other people are going through the same thing, and those are people you can talk to about some of the worst things in your life, then like that's in a way how resilience gets. And that's some of the strongest relationships you'll ever have. I mean, it's not comparable to what a parent goes through, so don't think I'm trying to make that connection. But when trainees, like residents and fellows, the training we go through, some of the people you have the closest bonds to, whether you stay in touch with them a lot or not, are people that you've gone through, the nurses, the other clinicians, your other co-fellows, that you've taken care of some pretty rough things in the ICU yourselves. Now, again, they're not your own children, so it's not the same ball game at all. But in terms of the resiliency you have of going through that together and weathering it, and knowing that you're not the only one who's seen this, who's been a part of this, who's failed at this, who's tried to help at this and felt worthless sometimes, I think that's that's the importance of the community. And I think one of the reasons we all love CNOC so much and love having parents and families at the CNOC scientific sessions is because it's always, it may be tough sometimes, the initial thing to talk about things that you haven't talked about before, but in general, the people that engage seem to leave a fuller individual with a greater appreciation of what they've been through and what it means and how to live a full life.
Yeah, I don't think you realize that the first part of what you said there is going to be a sales pitch for my entire podcast, which is the power of community and storytelling. But it's reminding me of when I talked to the Adult Congenital Heart Association's peer mentors when they were doing the recruiting for that. And I had a friend of mine, Rick Pewter, on, and I clipped what he said, and I have watched it a million times because I worked it into everything. It's good to have someone who gets it, who's been to the appointments, who's had the surgeries, who's been in your shoes. And that is something that, I try to put stories in front of patients so they know that there are people that have gone through it and come out the other side better for it. Better seems like the wrong word to say, but it's not. I mean, patients seem to have this resilience and this focus on what comes next because they appreciate what they have, what you all have given us, really. And it's just, this is just another extension of that. It's getting patients in the same room so they can guide and be guided. Two sides of the same coin. Anyway, I think we need to get a bunch of patients at CNOC in one way or the other and their family members. These scientific sessions, does anyone have the actual dates and times in front of them? Just something I have that somewhere. This is great. This is wonderful.
So it is September 16th through the 18th in Wilmington, Delaware. And I think, Drezden, you said at the beginning, it is hybrid. So you can come in person. We would love to have you in person, but we also recognize that is a huge ask. And so there's a virtual option, and virtual attendance is free to patients and families. So even if you think that you can only, if there's one session or one talk that you want to sign in for, please register. Please just come, even dip your toe in the water of CNOC. I really, really think that it will pull you in. It's a great community. And there's ways, like Drezden said, to interact. If you are joining us virtually, there's online questions, and you can email each of the speakers. You can interact with the posters that are there and email them. So even if it's virtual, there's lots of ways to engage. So please come join us.
And these people will be so excited if you email them about their research. And if you say you're a patient, I mean, it seems, I can't think of any other example where when you go watch a presentation about something important and you reach out to the speaker that they're this happy to hear from you as a patient. It's the opposite of the presentations you go and pay for. These people actually give a shit about what you have to say. So please watch and please email. Before we wrap up, and I skipped a lot of great questions here, but this is one I refuse to skip. I always ask all my guests, and I usually get resilience in some form and hope, but it shifts a bit with providers. And now with everything we talked about being so, this is going to feel like a meta question, but what does CHD mean to you? Not the medical definition, not from the textbook, not what it actually is, but what does this condition and the associated care and all the work you guys do mean to you now after all the hours you've put in for your career, for CNOC, for your life? Whoever wants to answer first, that's a tough one, I know, but what does CHD mean to you now?
I mean, that is, even being prepared for this question, it still is a hard question. It's, and I know we've used this word a lot, but I think to me, CHD is community. I've really been blown away how much I have just fallen in love with this field. My entire identity was wrapped around being an ICU nurse. I loved it. I was really good at it. And then I got burnt out. So CHD has become this community for me that I didn't know I was going to find again. And I feel really grateful to be able to be involved in families' lives still in a really intense and kind of intimate way, from their hardest days in the ICU and then seeing them as teenagers in our outpatient program and having them tell me about all the successes they're doing and their summer plans. And I just am so grateful to be a part of that.
Tom, before you answer, I just want to say one thing there. It is amazing that you say that, because it was almost the same wording as when I asked a father, the Connor of the Stronger Hearts Foundation, who I actually met at CNOC, who made a foundation after his child was diagnosed last year, and it's just had phenomenal success. It's community. Amazing. Sorry to cut you off, Tom.
No, I mean, of course, with Andrea going first, she took what I was going to say. So as I was listening to her talk, I'll go even one step further in terms of what CHD means to me. May sound not appropriate, but it's family too. I mean, on a few different layers, right? Like we talk about when we go to the CNOC scientific sessions, we feel like more than any other meeting for a lot of us, we feel like these are our people. And it's almost like this is our family. Yeah, maybe for some of it's our work family. But as someone who feels, and I truly mean this, feels blessed for families to let me into their life. Not that they really let me. I sort of forced my way in by diagnosing their child. But
we're not complaining.
But let me be a part of some of the hardest days of their lives and some of the best days of their lives. Like I can tell you families that when we have a quick follow-up clinic after they've been through a lot and they're like, so work in May, and they're like, we're out of here, we're headed to the beach. And if you don't want to see us for another year, that's great. That's what CHD means. This is where I'm far enough along in my career that this is where I'm most comfortable. It feels to be, whether it's cardiology clinic, whether it's the OR, whether it's the ICU, whether it's at a CNOC meeting, this is what I know. This is what I like to do. These are the people I like to be around. And these families, now I hope I understand a little bit more because of them coming to meetings and me hopefully trying to listen to them. I understand and can feel like I'm part of their family as well. So maybe corny, but yeah, I'm going to go with family.
I don't think it was corny. I think the part, again, taking a step back, the part you guys that I want listeners to hear, because I don't want it to be missed here, is that you guys you're not patients, you're not parents of CHD patients, I think. You have no personal connection to this thing that has impacted me and impacted all of my friends so much for so long. And yet you guys are, like you're saying, community and family. It's amazing how many smart people have dedicated their lives to making my life better. And for any patient listening, it's amazing it's amazing what you guys do. Now, one last thing I want to get in before you fuckers make me cry is, at this conference on Friday, September 18th, the same conference, I'm giving a presentation about living inside the outcomes. I've named it Neuro What, because I had to ask you two for what neurocognitive optimization was a few times. Neurocognitive optimization? Yeah, that's what it was. So I said Neuro What, living inside the outcomes. It's the patient side of everything we discussed. So if you have listened to this whole episode and you have made it this far and have something to say that you want to make sure these guys hear, send me an email, support@1%heart.com. Send me a message, Instagram @the CHD podcast. I will get it worked in somehow, some way. Help me guide my presentation. And if you want to talk to the guest today, or if you want to figure out who you want to tell your story to, reach out those same two avenues. I'm sure I know somebody that would love to hear your story. If you can't get to Delaware, sign up for the Zoom. Just look at cardiacneuro.org. It's going to be linked in the show notes. It's worth looking at just how many options there are for 3-4 full days of this research being presented in an engaging way. All that to say, that was Dr. Tom Miller and Andrea Smith. Thank you guys so much for being here. Cannot wait to see you in September. And appreciate your time.
Thank you so much. This was really fun, and I can't wait to see you in person. And yeah, thank you.
Yeah, thanks.